Hello everybody, my name's Duncan Bootland, and what I'm going to try and do over the next 40 minutes is give you my top 10 tips for critical appraisal. So for those that don't know me, this is me, and I'm an emergency physician. I spend about half my time working in the ED in Brighton on the south coast of England, and I spend the other half doing HEMS work with Kent, Surrey, Sussex Air Ambulance. And this is the image I like to think of myself as, going and doing exciting medicine. And certainly I do think of myself first and foremost as a practicing clinician. But those that know me really well know that I have an interest in critical appraisal. And along with some friends and colleagues, I teach on a critical appraisal course for the Fellowship of the Royal College of Emergency Medicine exam. And we've written a couple of textbooks. And the most recent one was published just last week. And it would be absolutely remiss of me not to give it a good plug in this talk. Now, the idea for the talk came from a friend of mine, a chap called Matt Miller, who asked me to come and talk about critical appraisal. And he said to me, do you think you could cover the whole of critical appraisal in 40 minutes? And I said to him, well, Matt, the course we run is 2 days and the book we've written is 200 pages. So that's a pretty big ask. But what I did think we'd be able to do is come up with some tips and tricks that we might be able to cover in the next 40 minutes that will give you a bit of a guide when you're starting out learning about critical appraisal and starting out reading papers. Now, before I start, I don't want to make out that this is the only thing you need to know, and I would heartily recommend everybody goes and learns this stuff properly. Get a good textbook, go on a good course, doesn't have to be ours, but hopefully for those of you who are just starting out on this, this will help you when you're reading papers and when you're trying to interpret the evidence base that is out there. So I'm going to start with this fella. This is Dr. Kevin Fong. He's a consultant anaesthetist and intensivist at UCL hospitals, and he's an emeritus doctor with Kent, Surrey, Sussex Air Ambulance. And Kev really kindly wrote the foreword for our most recent textbook. He stood there on the Royal London helipad. He stood in front of the London's Air Ambulance, which those who know me will know that I consider that the wrong colour helicopter, but we'll forgive him for that because he wrote us a lovely foreword. And what Kev talks about in the foreword is that, say 100 years ago in medicine, the interventions, the treatments that we had for our patients, they were fairly blunt tools. And we made an assumption that the outcomes of the patients were dependent on the interventions we provided for them. But in modern medicine, the benefits we see from the interventions that we provide to our patients, or the harms that they suffer from our interventions, are usually measured in a few percent. And that means that when we're treating them, as Kev says, in medicine today, the benefits we deliver and the harms we inflict are largely invisible. Just because the patient gets better, or just because the patient has a side effect, doesn't necessarily mean that's because of what we've done to them. And that means that we can't really trust our eyes. We can't really know that what we're doing is what causes the patient to get better. And that means that we must all have a good understanding of the evidence-based literature and how to interpret it for us to be able to provide the best care to our patients. And so that's my first tip. We've all got to be good at this, and so we've all got to practice it and learn it. This fella is Dr. Gregory House. So he's not real, but he's got some brilliant catchphrases. And one of them is that he says it's a basic rule of the human condition that everybody lies. The only variable is about what. Now that's a pretty jaundiced view, and even as an emergency physician, I'm not sure I quite sign up to that. But I am cynical, and so I would convert that slightly, and I would say it's a basic rule of the human condition that everyone has their biases and agendas. And by that, I mean that when you're reading the evidence-based literature, you always need to be slightly cynical about what you're reading. And I'll give you an example of that. So this is a trial called the Caesar trial. It was published a few years ago now. I'm looking at the benefit or otherwise of ECMO in people with respiratory failure. At the time, it caused quite a lot of discussion, particularly because it was published in the teeth of the swine flu epidemic. Now, the reason I bring this up here is that the result, and we could talk about what the result actually means, was widely publicised. But when you look at the list of authors in this, there are a number of people in the author list who are ECMO specialists. And what I would say is that when you read a paper like this and you see that there are loads of ECMO specialists, you can't tell me that they didn't go into that study having some opinion about ECMO. And they're almost certainly going to think that ECMO is a good thing. That's a bias that they take into their study. It's an agenda that they have. Naturally, they're going to want to produce a study that shows that ECMO was of benefit. Now, that's not to belittle their trial, it's not to belittle their result, but I think just all of us need to be cynical and aware of these things when we're reading the literature. There was a wonderful quote from a doctor on an internet forum about this trial after it was published, who said this was a negative trial written by enthusiasts. You don't get more damning than that. Now, you can agree with that person or you can not agree with them, but I think that's the sort of cynicism I take in when I'm reading papers. Next, I wanted to talk about this. So the St Emlyn's blog is an amazing resource for all of us to use, and I'm just massively impressed by the people behind it all. I think what they do is phenomenal. And this is a blog post by Natalie May, published I think about 2 years ago. And I saw this pop up and I thought, this looks like something that would interest me. So she called it Drinking from the Fire Hose, How to Stay on Top of the Published Literature. And I thought to myself, I'm interested in critical appraisal, but like everybody, I see this mass of papers that are published every week, every month, and I think to myself, how on earth do I keep up with it? And I thought, I'll read this and I'll see if this will give me some tips and tricks. So what Natalie talks about, she tells you how to go about setting up a PubMed search. So an automated PubMed search that you can run every day or every week or every month. And the search gets generated and then it'll get emailed to you and it appears in your inbox whenever you want it to appear in your inbox. And so I thought to myself, well, I'm kind of interested in pre-hospital medicine, I'm interested in trauma and resuscitation, I'm interested in emergency medicine, and I dual trained in critical care, so I'll put critical care in as well. And I thought to myself, well, look, I'm not one of these high-performing individuals. I don't clear my inbox every day, so I'll have it come in every week. I'll have it come in every Saturday morning, and that will help me keep up to date with what's going on in the areas that I'm interested in. And that's what happened. So the first Saturday, this came into my inbox, and the observant of you will notice that it had flagged up 1,835 papers. And I thought to myself, well, maybe, because this is the first week, maybe that's just like a backlog of papers, and next week it will be better. But it wasn't. And it's essentially every Saturday morning I get about 1,800 papers in my inbox. Now, I don't know about you, but there is no way I can make my way through even 1,800 titles, let alone 1,800 abstracts, or certainly 1,800 papers in a week. And the reason that I'm getting 1,800 papers every week, of course, is that my search criteria is too wide. And so I'm getting a whole load of stuff that is really not of interest to me. But the problem is that if I narrow the search criteria down, then I'm going to miss stuff that is of interest to me. And so what I really like Natalie's blog post, I'm not sure you can drink from the fire hose. I think if you try and drink from the fire hose, this is what happens to you. And I don't think that working smart is cheating. In fact, I think quite the opposite. And so then the question is, how can we work smart? And I do that in a couple of ways. First and foremost, I rely on some stuff that is out there online. Now, I've put Twitter at the top of the list, and I perhaps shouldn't have done that. But I do use Twitter, and I use Twitter because There are some very interesting, some very bright people out there posting stuff on Twitter. There are some weird people as well, there's no doubt about that, but you can use Twitter to point yourself in the direction of papers that are coming out that are interesting, that's only just come out, and so it can be quite an efficient way of picking up stuff that you might otherwise miss. Now, I absolutely do not take everything that's put on Twitter at face value, in fact quite the opposite, but I do use it to point me towards papers that I might find interesting. I also use some of these websites, educational websites that I've listed below. These are the ones that I think are particularly good, and the people behind these I'm very, very impressed by. These people don't seem to sleep. They put a huge amount of work into providing free resources for people. I just think they are absolutely massively impressive individuals. But what they will do is not only will they point you towards up-to-date research, not only will they point out stuff that you might otherwise miss, but all of them will actually critically appraise the papers themselves. And it can be really seductive, because not only does it mean that you're getting pointed towards the paper, but to some extent they will give you an answer about whether you should believe that paper or not. Now, like I said, I'm very impressed by these websites, I'm very impressed by these people, but I would just remind you of tip 2, and that is that you have to be cynical about everything, and everybody has their bias and their agenda. So the people who are critically appraising the articles on these websites, whilst almost always I agree with what they say, you have to remember that they have their own bias, they have their own agenda. And the bit of advice I give to people is that if you read stuff and you think, the person writing this doesn't seem biased at all, they don't seem to have an agenda, well, maybe that's just because their biases and their agenda absolutely match yours. So I would always recommend that even when someone's done the critical appraisal for you, somebody you trust, somebody you like, go back and read the paper, because you may well pick up on stuff that they've missed because of their own little blind spots. And I think that's just good practice. Another website that I use a lot is the New England Journal of Medicine Journal Watch, and what they do on there is they essentially take that PubMed search every week and they thin it down to about 4, 5, 6 papers, and then they will email you the links to those articles every week. So instead of getting 1,800 papers, I get 4, 5, 6 papers a week. Now, I accept that the people running that have their biases and their agendas, and they may be missing stuff that is of interest to me, but I do find that quite an efficient way to keep up to date, certainly more efficient than trying to make my way through 1,800 papers a week. And the final thing I would say is that when you pick out the papers that you're interested in, like I say, don't rely on other people's critical appraisal. Do a little critical appraisal yourself. So this is the template I use when I'm reading a paper, and this is from the Proper trial a couple of years ago, and that does 2 things for you. The first is it makes you read the paper properly. The second is that for all of us, when we read a paper, we think at the time it's interesting, and we understand what the lessons to take out of it are. But if somebody comes and asks us a few months later, certainly a year later, it can be a challenge to pull that information out from your brain. And rather than have to go back and critically appraise the paper from the start, I find these documents quite happy because they're my quick cheat sheet. It's my critical appraisal, but it's a quick cheat sheet when I come back to it. And so whenever I'm using a paper in an educational session or a presentation or in a paper for something else, then I will critically appraise the journal article that I've read, and then I've got a quick 1.5 page, 2 page cheat sheet in my own words that describes what they did, what the outcome was, what the pros and cons of the trial were, and what the conclusions were and what the conclusions should be. For anyone who's interested, I'm very, very happy to share the pro forma I use, but there are loads and loads of them out there. They're fairly easy to do. Tip 4. The question should come before the answer and at the end of the introduction, and that's to remind me of 2 things. We'll start at the end first of all. So in good quality journal articles, the research question is usually written in the last paragraph of the introduction. And what that means is that when you're short of time and you want to get a good feel for a paper, the bits of the paper I would usually read are the last paragraph of the introduction. I wouldn't bother with the first bits if I'm short of time, because that's just background information. But the last paragraph will tell me what the researchers were asking. And then I'll read the methods, and then I'll read the results. And I'm going to come at the end to why I don't always bother to read the conclusion. But those are the bits that I would read. So if I'm really short of time, the last paragraph of the introduction, the methods and the results. And then the first part of my tip, the question should come before the answer. So in research, what we should do is start out with a question, a clinical question, and then we should go looking for the answer. Now, when you run a service and you have a database with loads and loads of information in it, there is a temptation to have a set of data to essentially have an answer and then go looking for a question to fit that data or to fit that answer. It's widely done. Retrospective analyses of databases is widely done, it's widely published, but it's not really the right way to do research. And so it's not unreasonable to go and search a database looking for an answer, but the researchers should have had a question and then gone looking for where they're going to get that data from, rather than having a load of data which they kind of know what answer it gives them and then trying to formulate a question so that they can write a paper. And when you're reading the paper, you should be thinking about that. Have the researchers come up with a question and then gone looking for the answer, or did they have a load of data and do they keep asking questions of that data because they think they have some answers that they can get published? Tip 5. So voyeurism isn't as good as taking part. And the message behind this tip is that as a general rule, interventional trials, so trials where the researchers do something to the patients, are better than trials where all the researchers do is sit and watch. So if you imagine randomized control trials, the researchers or the trial influences whether the patient gets treatment A or treatment B. That would be considered better, more valuable information than an observational trial like a cohort trial where the patients might get treatment A or treatment B, but the researchers, the trial doesn't dictate that. That just happens as a natural part of their medical care. So interventional trials are far higher quality, are considered higher quality than observational trials. Observational trials, as a general rule, should be hypothesis generating. They should get us to think about, oh, maybe this is of benefit or maybe this is of harm to patients, and then we should go and run an interventional trial. Now, I've put an asterisk at the end of that tip, and the reason that I put an asterisk at the end of it is because that is true up to a certain point. So when you're thinking about grades of evidence, interventional trials always come above observational trials. But I don't want you to go away thinking observational trials are just complete rubbish. And I've sat in journal clubs where people have said, this is an observational trial and so it's worthless. And I really don't sign up to that. And the reason I don't sign up to that is twofold. Firstly, there are some interventions, there are some treatments that ethically or practically are very difficult to run randomized controls for. Maybe the disease is very, very rare, or the outcome of not treating the patients is death or serious, severe pain. And you might think it's unethical to run an interventional trial where there's a control arm that doesn't get treatment. And so there are situations where observational trial data is the best that we can hope for. And the second thing is that there are a number of situations where observational data, observational trials have revolutionized what we do in medicine. So if you consider smoking and you consider the British Doctors Survey from the 1950s through to 2000, that was an observational cohort study that changed the world. And likewise, if we're thinking about something in the more recent past, if we think about the work that was done originally around massive transfusion and high ratio blood transfusion in trauma, all of that data from the military and then in civilian practice was observational data until the proper trial in 2015. And that data has revolutionised how we manage massive transfusion in the Western world. Now, you can argue whether that's a good thing or a bad thing, but to belittle observational data and say it's worthless, I think misses the fact that there are observational trials out there that have had a massive impact on what we do in medicine. So don't just scrap them when you're reading them. Think to yourself, does this actually work as a interventional trial? Is this the best we can hope for? If it is the best we can hope for, is it telling us an important message? So this is a slide for the British people amongst you. I know it doesn't translate outside of the UK, but tip 6 is consider, is this a local trial for local people? Now, when patients are enrolled in a trial, one of the big questions for those of us who are reading the trial is, the patients who are enrolled, are they similar to the patients that I treat in my practice? Is it the same environment? Is it the same sort of patient? Is it the same disease process? Are they as sick as the patients I'm thinking about treating? Because if those things are not true, you have to start to wonder, can I generalise the result of this trial to the patients who I'm about to treat? A good example of that is when we're thinking about the patients we treat in emergency medicine in our emergency departments and compare it to the patients that are treated in general practice. Those patients might at first glance seem very similar, but in fact they might be very different. If you present to general practice with chest pain, you might be different to the sort of patient who presents to the emergency department with chest pain. And so we need to consider that and be cautious about generalising results from one group of patients into another group of patients. However, everything comes with a caveat. Just remember that very few of us are lucky to work in a centre that enrolls lots and lots of people into high quality randomised controlled trials. So to some extent we always have to generalise results. And that's particularly true in pre-hospital care. So over the last couple of years there have been increasing number of trials done in pre-hospital care, but often in pre-hospital care we have to generalise results from emergency departments or critical care to the patients we're treating in the pre-hospital environment. Personally, I don't think that's unreasonable as long as you're aware you're doing it. But at some point you have to say the patients that were enrolled in this trial are very, very different to the patients I'm treating, and so that result is not generalisable to the patients I'm treating. Tip 7. Good old Einstein. So, if you can't explain it simply enough, you don't understand it well enough. People who overcomplicate things, to my mind, are generally trying to hide something. That's a bit cynical, isn't it? But there you go. So tip 7, you only need to know a couple of things. In interventional trials, so randomised controlled trials or observational cohort studies, you really only need to know absolute risk reduction and number needed to treat. So I'm a really big fan of not overcomplicating critical appraisal with loads of formulae. But we're going to do a couple now because this is important. So for me, when I'm reading a paper, an interventional trial, the only real thing I want to know is what was the outcome in the intervention group and what was the outcome in the control group. So let's talk about mortality, for example. So when I'm thinking about absolute risk reduction, I'm thinking about how many people, what percentage died in the control group, what percentage died in the intervention group, and what was the simple difference between the two. That gives me a nice, easy number that I can understand, that anyone can understand, that tells me about the value of that intervention. And then from that, I can quite easily calculate a thing called the number needed to treat. So the number of people I have to give this intervention to save one life or to get one positive outcome. Save one life if we're talking about mortality. And that is simply 1 divided by the absolute risk reduction. Now you need to know a little bit about statistics here, because you need to know that absolute risk reduction is not written as a percentage, it's written as a decimal. So if it's a 2% absolute risk reduction, it's written as 0.02. But that's as complicated as it gets. And those are the only two things you need to know. Absolute risk reduction, number needed to treat. If you tell me the number needed to treat for an intervention, then that makes it easy to understand. Aspirin in acute myocardial infarction, number needed to treat 42. Costs pennies, only need to treat 42, I save one life. That's amazing. When we're talking about diagnostic studies, so that's comparing, for example, the ability of troponin to diagnose acute myocardial infarction versus cardiac MRI, something like that. There are only 3 different results we want. And the important thing when you're thinking about diagnostic tests is that the different results are important to different people. So when people talk about diagnostic tests, they often talk about sensitivity and specificity. It's widely quoted. Now, sensitivity and specificity give a really nice overall judgment on how good a test is at ruling in and ruling out, and we can run through the maths of that at another time perhaps. But actually, an overall judgment on how good a test is really only of interest to biomedical scientists. It's not of interest to the clinicians, and it's not of interest to the patients. What the patients care about is, you've given me this positive test, does that mean I've got the disease? Or you've given me this negative test result, does that mean I've got the disease? The result that they're interested in is the positive predictive value. For the clinicians, it's different. For the clinicians, what they're interested in is, I took this history from the patient and I examined the patient. I thought they might have disease. In fact, I thought they had a sort of moderate level of risk of having this disease process. Now I've done this test, this blood test, or this X-ray, or this ultrasound, and it's said that they do or they don't have disease. When I'm combining the test result with my examination and history findings, now, do I think they have disease or do I not think they have disease? So, for example, I examined them, I took the history, I didn't really think they were having a myocardial infarction, but their troponin is slightly raised. Does that mean they have acute myocardial infarction? And so what we're interested in is the likelihood ratio of the test, because we combine the likelihood ratio with how probable we thought disease was before we did the test to come up with an idea about how probable we think there is disease after we've done the test. Now, the maths of that takes some explaining for all 3 of those results, but I just wanted to highlight that for diagnostic tests, patients care about predictive values, positive and negative predictive values, and clinicians care about likelihood ratios, positive and negative likelihood ratios. Sensitivity, specificity gives you an overall view about the value of a test, and it's kind of interested for the biomedical scientists, the people who have to decide, are we going to buy this test or are we going to buy a different test? Tip 8. So tip 8 was given to me by an intensive care consultant a number of years ago, and it's kind of stuck with me for the rest of my career. So any critical care trial needs at least 1,000 people in each arm. And I know that this might unsettle some of the statisticians who are out there, but I just want to try and explain this. So this goes back to what Kev Fong was saying in the foreword of the book. So in modern medicine, we should never really expect massive drops in mortality or massive changes in outcome from any new intervention. The big drops in mortality, the low-hanging fruit or silver bullets, they almost certainly have all already gone. So we shouldn't really expect in critical care any drop in mortality from a new intervention that's any bigger than 4 or 5%. Drops that are bigger than that, personally, I'm a bit suspicious about. There may be some out there, I take it there may be some out there, but I'm always slightly suspicious when people run trials and when they're working out how many people they want to put in, they say they're going to expect a difference between intervention and control that is more than a drop of 5% in mortality. And the reason that's important is that when you're trying to work out how many people to put in the trial, one of the key factors is how much of a difference you're expecting between the control and the intervention arm. And you base that on pilot studies, you base that on work that's already been done by other people. And so to some extent you're a bit tied by that. But I still hold on to this. If you're expecting a mortality drop of more than 5%, there's a big bit of me that thinks, why are you expecting that? That would be absolutely remarkable drop in mortality. And the way that you calculate the number of people is you run a thing called a power calculation, and as part of that you put in what you're expecting as the difference between the two arms. And if you put in about 5%, that comes back to you in a simple randomized two-armed control trial with about 1,000 people in each arm. And so that's where this tip, any critical care trial needs at least 1,000 people in each arm. And so when I read trials where they've put less than 1,000 people in either arm, I ask myself two questions. One, did they do a power calculation? Because if they didn't, that's a real criticism of the trial. And two, if they did do a power calculation and their power calculation told them to put in less than 1,000 people in each arm, was the mortality drop they were looking for between the two arms, well, was that just too ambitious? And I'm going to give you an example of that. And that's the proper trial. So this is the trial from 2015 that looked at 2 high ratio blood transfusion strategies in trauma patients who are likely to need a massive transfusion. And they enrolled about 340 people in each arm. So it fails this tip 8 of mine, where I think this is a critical care type trial, they should have 1,000 people in either arm. And that was because they were looking for a 10% mortality drop between the arms. And they based that on work that had gone on beforehand, the observational data that I sort of alluded to earlier, and that's fine. But, as I said, there's a bit of me that thought, well, 10%, that would be a massive drop in trauma mortality. And what their results showed was that there was a non-significant difference in mortality between the two arms. So they report their trial as saying that there was no difference in mortality between the two arms. But actually what their results showed was that the difference in mortality between the two arms was just over 4%. But because it was only 4%, it didn't reach statistical significance because the trial was powered for them expecting a 10% mortality drop. Now, if they had powered the trial for a 4%, 4.5% mortality drop, and they had put 1,000 or more patients in either arm based on that power calculation, well, maybe, and it is a maybe, but maybe that 4% mortality drop they saw, maybe that would have been clinically significant, or statistically significant. And that would be really important. A 4% mortality drop in trauma patients, well, that would be big news. That would be massive news. And so, like I say, whenever I read a critical care trial and there's less than 1,000 people in each arm, I'm really, really careful to look at, did they do a power calculation? And if they did, were they just looking for too big a mortality drop? And that's, I would wonder that about the proper trial, whether they just were looking for too big a mortality drop. After all, they didn't really compare low and high ratio, they just compared 2 high ratio blood transfusion strategies. And that leads into my tip 9, and that is don't dismiss negative trials. So I will admit that when I first started out reading papers, if the result was non-significant, non-statistically significant, then I would say, well, we can just discard that treatment. That's pointless. But based on what I've just said about the number of people who are enrolled in a trial, and the fact that sometimes, in my opinion, researchers are a bit ambitious about the mortality drop they're looking for, then that makes me think that if I see a negative trial, what I need to ask myself is, well, maybe they were just too ambitious in their power calculation. Maybe they didn't do one, but maybe if they did, they were just too ambitious. And if they were too ambitious, does their non-significant result hide what might actually be a really important difference between the control group and the intervention group, like I described with proper? Because we run the risk, if we throw away all the negative trials, of missing a whole load of benefit for our patients. It doesn't mean that we should take proper and say we don't believe their results, we don't believe their conclusion, but we should think to ourselves, well, maybe it's worth rerunning that trial and enrolling 1,000 people in either arm. Or maybe this is where meta-analysis might benefit us. We run a different trial, maybe in the UK or Australia or Europe, and we get ourselves a few groups of patients, a few trials that we can meta-analyse and bring them together so that this negative trial, if we combine it with some other trials and we get the numbers up, maybe then it will show that there is a significant difference between 1:1:1 and 1:1:2. I don't know, but that's why nowadays I don't just routinely dismiss negative trials. So my final tip for you comes back to what I said near the beginning, and that is that when I'm rushed for time, the bits of the paper I read are the last paragraph of the introduction, the methods and the result. I'm interested in the question the researchers asked, I'm interested in how they ran their trial, I'm interested in the results that they got. But I know that they have their agenda and their bias, and their conclusion, whilst hopefully it reflects the results, is going to be in some way influenced by their agenda and their bias. And so what I think is that the conclusion is the readers to write. It's not the authors to write. You should read the methods, you should read the results, and you should formulate a conclusion before you read the author's conclusion. And often it's valuable to compare the conclusion that you've reached to the conclusion that the author's reached. And that will sometimes help you tease out any biases or agendas that the authors might have that you might otherwise not recognise. And when I showed you those critical appraisal crib sheets that I write out for the papers that I read, that's what I do. I write what the authors have concluded, and then I write what I conclude about the paper. And I think that that makes an interesting comparison. So that's my top 10 tips for critical appraisal. I hope you've enjoyed it. As I say, it's not a substitute for going and learning it properly, but hopefully for those of you near the beginning of your journey learning about critical appraisal and reading journal articles, that will have been of some value. If you've got any comments or questions, by all means get in touch with me. That's my Twitter handle. I'll be happy to answer questions.